for hospice. In hospice, you need 2 doctors to certify that you have a terminal status. And that's the same sort of criteria that's needed for the End of Life Options Act. There is a mental health evaluation that the primary care physician can do, or they can send out for a consult for the End of Life Options Act if patients are interested in that. But I do want to say that one of the great things about the End of Life Options Act is that the physicians are required to counsel the patient on other alternatives, such as hospice. So it's not like, a patient comes in and says, I want the medication, and then they get it the next day. There's actually a lot of built-in redundancies. They have to make a verbal request to their doctor, and then some time period has to pass. I believe it's 14 days. They have to make another verbal request to another doctor, and then a few more days go by, and they have to make a written request. And then all of those things then kind of get the process going. Then they have to find a pharmacy that will obviously carry the medication. In California, and specifically here in Lake County, the providers who are going to be willing to sign off on those are kind of up in the air. We don't know any local providers that are willing to do it. And I was just sharing with Bill before the show started, in Washington, where I have experience with this sort of legislation, it required the same sort of steps, the 2 doctors and the mental health evaluation in the pharmacy, but there's not always in those sort of providers available in those counties, especially when you start to look in rural areas. In Washington, I believe my memory is correct on this, out of the 56 counties in Washington, only about 6 were able to have all of these providers able and willing to do this sort of thing. Medical professionals, for those of you who are listening, are completely voluntary. You can refuse to participate. So no doctor is required to do this, no nurse practitioner, no physician assistant. And the same thing with our local hospice agency. Our hospice staff aren't going to be required to assist patients. We have, actually we're reviewing and updating our policies and procedures right now. If a patient of ours asks for this medication, and coincidentally we just had some patients mention it to our clinical staff, then if the clinical staff don't want to be part of that case anymore, or that patient's care, then they can opt out, and we will reassign a clinician who is more comfortable with it. So so it really does help protect and help the healthcare providers.
But I just through the California Pharmacy Association on Monday night, I had a webinar, and a clinician was giving us the directions on how pharmacy would be involved in this. And of course, at any time that the patient could opt out at any place along the way, Absolutely. Even after they'd been prescribed the medication. Yep. And I think that the difficult thing for a couple of things for pharmacy was that the length of this process, similar to the hospice procedure, and the amount of, even if we dispense the medication and we know that this isn't for that, it's a felony for us. So, and at any time, if there's a problem in the process, even the difficulty was the patient has to ingest this. The specific law in California and maybe in Washington was that the patient could not have somebody else assist them in the process of actually taking the medication. They had to be able to. So if you're paralyzed, if you're quadriplegic, if you have Parkinson's disease, if you're demented, and not able to understand this process, then you're not a candidate. So
that's right.
It was interesting when you told me the amount of participation in the state of Washington, because I anticipate, and so did this clinician that was giving the webinar, that people aren't going to be rushing to get into this process. Although we had people moving to Oregon and Washington to declare a residency so they could participate in this. But what I really wanted to stress about hospice is in all my dealings, the death with dignity is definitely there. We have situations
Absolutely.
where you know and your staff knows really the process the people that are dying go through. The anxiety that's created, and the amount of pain that they're going through, and what the process is when the body is shutting down. And one thing that enlightened me about hospice when I was directly involved was every week we met. The whole room full of everybody from the social provider to the person that went and gave them baths and everything, to the entire process, that everybody was involved. It wasn't here with the Death with Dignity Act. It's trying to keep everybody else away and the involvement just be the patient.
Yeah, you're absolutely right. And actually, we still have that practice. Every morning, all of our clinical staff meet to talk about patient issues and how we could better serve the patients and what kind of care is needed to improve their care. And I kind of agree. And many hospice agencies that we're involved with are taking different approaches to their level of involvement for patients who are asking for this sort of a service, the End of Life Options Act. There are some hospice agencies in our coalition that if a patient asks to learn more about this, then they're just simply going to say, if that's something you're interested in, we're not going to be able to take care of you, and they'll move forward with discharging them. What we've decided to do is we've decided to support the patient as best we can, educate them about other options. We obviously want to know if there are concerns that they have or care issues that aren't being met. Because for some people, it might be that that they have a specific want or need, and we just don't know about it yet. So to really talk with them and see what we can do to improve any care issues, whether it's pain management or whether it's anxiety or whether they just don't want to be bathed. There's a whole lot of options there of why somebody might not want to kind of go the natural way. And so our goal is really going to be to really communicate with them and try and solve those issues so that they can die with dignity. You're absolutely right. There's not going to be a rush to get this sort of a medication. In fact, the percentage of people who even pursue this is so minuscule. Through all of the deaths in Washington, I don't know how many people die in Washington each year, but every year they come out with a report on the people who are prescribed the medication. And so out of all the deaths in Washington state, only about 200 people get the prescription every year. And of those 200 people, only about 40% of them actually take the medication. So we're talking about 130 people actually taking the medication. It's not that big.
Well, one of the things that that people maybe don't understand, and I'm not in any way degrading this law, but what hospice does is so much more than that. I don't think people, you don't just go see the patient once a month and make sure they're okay and manage their pain. There's hospice care from the social aspect, from the physical aspect, from being a care provider. All that comes with the hospice environment, and it's just the opposite with this. And I think that it's if you're in a situation where it's all you can do to handle taking care of your loved one, and they have a terminal diagnosis and they qualify. That doesn't mean they, and correct me if I'm wrong, when I was there, they're evaluated on a periodic basis, and if it's gone beyond 6 months and they still haven't terminated their death is still imminent, then you can reassess them and reevaluate them, and they don't have to. As long as they're showing a process of declining.
Yep, exactly. And so we actually do that on a bi-weekly basis. We do it every 2 weeks. We review the entire case for every patient and figure out if their disease is progressing the way it should be progressing. We actually just have some patients this week who are actually what we call graduating, which means they came on service, they appeared to be appropriate for hospice when they came on, we provided care to them, and now after some period of time, they are either improving or no longer declining. And so we have people graduate off our service. But you're absolutely right. We do have a very kind of I always like to consider it like somebody giving you a big hug is what hospice is. I mean, we have social workers, we have nurses, we have nurses aides who are going to be doing all the bathing and all the personal care. We obviously have a chaplain to come and talk not only with the patient's spiritual beliefs but the family's spiritual beliefs. Obviously, at the end of life, it's one of those major life events, and it really shakes a lot of people's understanding of the belief system that they might hold. So our chaplain kind of comes in, works with them, can do last rites, or will work with other spiritual leaders of their particular faith to come in and also help. We also have volunteers, so we have a big volunteer program. Volunteers come in and they could provide some sort of a respite for the caregivers. If they want to go out and go shopping or go get their hair done or something that they just want to take a little break, we'll get volunteers to come in and help. It could also be that our volunteers might be reading to them or doing other things just to kind of make them happy. A lot of times when patients are nearing the end, they rest a lot. So even if our volunteers just come in and sit and read their own book while the patient's resting and the family's out. So hospice is a great benefit. One of the things that I think most people don't know about hospice is that it's completely free, and there's no strings attached to that, and it's hard to explain because when you talk about such an amazing benefit, how could something like that be free? And it's because we as a society decided back in the 80s that people shouldn't die painful, horrible deaths. And I'm not saying anything bad about hospitals, but they also didn't want people dying in hospitals. So they wanted people dying in their homes, carefree, anxiety-free, pain-free. So they created the hospice benefit, and it really hasn't changed significantly in the 36 years that it's been enacted. But it's, and even us locally, I mean, that's one of the great things about having a local hospice agency, because some of your listeners may have experience with hospice agencies elsewhere. As a local hospice agency, even if a patient comes to us without Medicare or Medi-Cal or any sort of private insurance, VA benefits, they come to us with no insurance, we will still take them on and we will still take care of them just as if they have Medicare and Medi-Cal. So that's one of the great things about being a local hospice agency supported by local people and local businesses is where we take care of everybody, even if they don't have the ability to pay for it.
Well, one of the points that you just brought up about the cost, interesting about the right to die law in California, or death with dignity, is that the federal government won't pay for this because it's not a federal payment program. The state Medi-Cal program will pay for it because it's a state program, and some of the insurance companies will, and they may or may not pay for the medication, which is from $3,000 to $5,000, and hospice isn't that way at all. And one of the things that you might have brought up, and I missed it, but is essentially another great part of hospice is grievance.
Yep, absolutely.
The ability, you might explain that just a little bit, but it's very important.
Yeah, so as part of the hospice benefit that was designed is every hospice agency is required to provide some sort of bereavement services to the family. And most hospice agencies, especially large national conglomerate hospice agencies, don't really do a whole lot. But we have 3 fabulous thrift stores, Middletown, Clear Lake, and Lakeport, and they provide us with financial support so we could provide a tremendous bereavement program. We have 3 bereavement counselors, Linda Lang, Kathleen Bradley, and Michi Brown. And we actually just finished a Wings of Hope program, a kids and families grief program, a 1-day camp a couple weeks ago at our office. We have a 3-day camp coming up in July, and then we have another 1-day camp coming up in October, in addition to the 16 or 18 different ongoing support groups that we have. We also provide bereavement services to kids in about 16 schools around Lake County, working with the counselors and doing little groups in the schools. All in all, we serve about 2,000 people a year in our bereavement program, and only a portion, I think 10 or 20% of our bereavement patients or bereavement clients have a relation to a hospice patient. The rest of them are community bereaved who maybe lost somebody from a car accident or some other tragic accident where they weren't related to hospice. So because of our tremendous support through our thrift stores, we're able to provide community bereavement to the larger population, and I just think it's a great program, a great service that we're able to do here locally.
I think that's a great thing to relate to our listeners, because you all have come across somebody who's lost somebody, and they may not particularly be with hospice, and they're having a hard time dealing with that, and they need to speak to somebody, and they don't have a connection with anybody. And you can call up hospice as 263-6222 and get that kind of support. I can't, our time's running short here, but I just can't imagine a community that doesn't have a hospice, and we are so fortunate in Lake County through the years, and I think since you've arrived, Corrigan, and Corrigan's not just the executive director of hospice, but he's involved in leadership in the county. I'm on committees with him. He's involved in Rotary. He's involved in almost every event you go to. You see Corrigan there supporting this community, and that means a tremendous amount to those of us who have been here for so long. And for those of us who have somebody, I mean, I'm 74 now. I may be the next the next patient. That to know that an organization like this exists, and all the people that are involved with your organization are extremely passionate people and caring.
Yeah, they are.
We are so proud to have you here, and I appreciate you taking the time.
We
Yes,
have
sir.
a call?
Okay. Hello.
Good morning. You're on Health Talk.
Yes, I'm a big fan of hospice. My father was treated with hospice.
Oh, did we lose you? I think we lost him, sir. Call right back. We'll get you back on. The transfer.
And he was even a supporter of
And he was
ours.
a
You're
well,
cutting
they
off the
usually are.
supporters.
By the way, on a sidebar, Bill, we have gotten some calls off the air. Many, many happy birthday calls for you.
Oh.
So
Thank you.
our listeners out there are wishing you a happy birthday today.
Okay.
So we didn't put them on the air because you guys were busy, but
Well, this was one of
gentleman.
our.
Yeah, let's have him call back. He'll probably with the delay is what's happening. It's going to take a couple seconds for him to hear us that we're asking him back. So continue on, and we'll get him when he gets here.
Okay, we just Corrigan. Any parting?
I would say one of the hardest things about working for hospice is the patients who come on, and they're only on, and I think that you mentioned earlier you had experience with this, they're only on for a short period of time. Usually they come on in the morning and they pass away that night. And hopefully in those situations we're able to make sure that they're comfortable and get them the medications they need. But hospice really is so much more. It's designed to help the families. It's designed to help with some end-of-life planning, such as organizing your funeral home arrangements and that sort of stuff. So we always encourage people to say, talk to your doctors and let them know that whenever you're terminal, just have them be honest with you and say, you're terminal now, and it may be time to call hospice.
We have our caller back.
Right. Good morning, and I hope it's our caller that we accidentally lost. Are you there with us?
Yes.
All right, good deal.
Yeah,
We'll be more careful this time. There you go.
with hospice, my father, he died of lung cancer. And in the final days, hospice just took over. He died relatively peacefully because they kept him with painkiller. He was under severe pain. And it was it was a very big help for the family.
Okay.
And is there some way that we can donate here locally to our hospice? I would like to do that.
Absolutely. So you could certainly donate to us financially at our Lakeport office. You could also make donations financially at any of our thrift stores. You can also donate products and items to our thrift stores, and you could shop at our thrift stores to help support us. So there's lots of ways to support your local hospice agency.
I'm sorry, I've got about half of that. It seemed to be breaking up. Can I go to the pharmacy there and they can give me the information?
Yep, Bill at North Lake Pharmacy will be happy to pass those donations on to us. Yep.
Okay. Well, thank you very much.
Thank you for calling. Okay, we're going to take a break. Thanks again, Corrigan.
Yeah, thank you, Bill. Appreciate it.
Anytime you want to come back, just let me know.
Will
be
do.
more than happy to have you.
Thanks. Appreciate it.
Did you know that according to the American Heart Association, heart disease is the leading cause of death among men and women in the United States? Hi, my name is Bill Kearney, pharmacist and owner of Northlake Medical Pharmacies. The good news about the heart is that a healthy lifestyle can prevent the vast majority from the disease. There are risk factors that you can't change, such as being male, being older, and a family history of heart disease. But other risk factors that you can change. Smoking. Do you know that 30% of all the deaths from heart disease are directly related to smoking? High cholesterol. Limit your fat intake and limit intake of cholesterol. Increase your intake of vegetables and fruits. Exercise routinely and drink 32 to 64 ounces of water daily. When these things are done in combination, they can drastically reduce your chance of developing heart disease. While these procedures are very important for people with risk factors, they're even more important if you've had a heart attack. Northlake Medical Pharmacy with 2 locations for you, and now free delivery to Lakeport, Nice, Upper Lake Lucerne, and now Kelseyville, the Rivieras, and Buckingham.
Sleepless nights, plenty of sleepless nights. Waking up in the middle of the night, can't go back to sleep.
Like when I first came back, it was kind of weird because like when I would be driving and a traffic light would go out or a light in the road would go out, that would kind of make me nervous. Because I'm thinking that at any second now something's going to explode.
I mean, that destruction. I mean, that's something that stay with you, and it surfaces.
Normal reactions to an abnormal experience. Military life and combat trauma can have a lasting effect on your mental health. If you or a family member are having trouble coping, remember you're not alone. It takes courage to ask for help. An anonymous self-assessment is available online and by phone. Take the first step to healing. Visit militarymentalhealth.org or call 877-877-3647.
Ever wonder what makes us, the Smurfs, so happy? The forest, of course! This is where we, along with the beautiful forest creatures, make our home with beautiful plant life, clean water, and endless adventures. It's a place to celebrate, so discover the forest with your family today. Visit discovertheforest.org to find a forest near you. Brought to you by the U.S. Forest Service and the Ad Council.
Here's the snap. It's a handoff to Rocky Carr. He breaks the tackle. He's at the 40, the 30, the 20. He could go all the way.
Not so fast, Rocky. Did you remember to register with Selective Service within 30 days of your 18th birthday?
No. Oh, too bad. Rocky Carr is stopped just short of the goal line. What do you make of that, Chet?
Well, Al, the law says that every man must register with Selective Service within 30 days of his 18th birthday. Now, Rocky could have registered online at www.sss.gov or at his local post office. Hey, it's the fundamentals, Al, and Rocky just didn't get it done.
You're right, Chet. That's got to be a big disappointment for a young man who had such a promising future. Let's see that again on instant replay.
Let's not, Al. It's pretty painful to watch.
All right, Bill, we're back.
Okay. Yeah. Well, we want to thank Corrigan for being here. He's an extremely wonderful individual who has done so much for hospice in Lake County. Excuse me. I want to just briefly give you some more details about that, and I won't spend much more time on it, but Corrigan, being from Washington, was able to give you a lot of directions on the procedures are going to be pretty much the same as they were in the state of Washington. So the best way to discuss this decision with your doctor is give him a question like, will you honor my request to hasten my death by writing a lethal prescription in accordance with the physician-assisted dying law? Now, there was an article in the Record B today about physicians and the right to die law in California. So there are all kinds of media information that's going to be coming out in the next couple of weeks. But as you see, it is quite complicated and very lengthy in the way that they suggested that the medicine has to be ingested. That means it has to be taken orally. And that means you as a patient or your loved one as a patient has to be able to take it on their own. It can't be a shot or something that's easy for them to take, or even a rectal suppository. It has to be ingested. So, and it has to be all done by the patient. So I thank you for listening to Corrigan. And part of what's going on today is because of the opiate addiction, and we've talked about that in the past, you're going to see more and more guidelines on that. But in case you're wondering about hospice and opiates, if somebody wants to be on oxycodone or morphine orally or those kind of things, that's entirely free from this new kind of emphasis on not prescribing opiates anymore. That doesn't require, is not a covered entity for hospice. They can prescribe what they want, what kind of medication they want, what route of delivery they want, whether we compound a cream, use it as a suppository, make it an oral solution or an oral tablet. There's all kinds of ways that they are able to give it. It's not restricted to what's going on. I just got back from Wisconsin. I had a board meeting with the board of directors, and we were talking about how the drug prices have escalated, and we were talking about people who get coupons to get their medication. If you're taking something like Jardiance or Brio inhaler or one of the very expensive medications, Belvig, which is for a diet, there's a coupon that you can get that makes your copay be reduced substantially. And what we're finding out by these coupons is your formulary is being restricted. That means the drugs that the insurance company is going to pay for, the window becomes smaller and smaller about what drugs they will pay for. I happen to be on a insurance policy through the pharmacy that restricts almost everything. I think I've taken 6 months worth of medication on the new contract, and they've paid $153 so far. I've paid almost $500 so far. So that means most of the medications that I take, they're not paying for. And that's going to be an increasing problem when we go to the free period to sign up on Medicare for Medicare D for patients in November and December, because the formularies are going to be restricted considerably. The other thing is that you're noticing in the Affordable Care Act, the price is going up substantially. And these drugs that are called specialty drugs that you're taking for MS and for diabetes and for a number of conditions, Parkinson's, are in the thousands and thousands of dollars, psoriasis. And the coupons make it affordable. But you're going to end up paying for the gap in between, and all that money that's being charged to your insurance company if you're on Medicare D is going to be counted as the amount of money, the amount of money an insurance company pays, as well as what you pay, are charged against you to go into the donut hole. So even if you're getting an expensive medication and it's costing $3,000 or $4,000, and they're paying for 75% of it, and you're paying for 25% or less on a copay, the amount the insurance company pays is included in the amount of money spent on your medication. Even though you're not paying it, it's charged against you. So just be aware of that when you have every right to ask a physician when you're getting a prescription, how much is this going to cost? And if they say there's a coupon, then you need to call your insurance company and make sure that your formulary isn't restricted on the medications that you're taking. And unfortunately, you have to initiate this. And we're doing it all the time with people with medications that are high-risk medications that are covered by the company, and where your copay is reduced, but it's still being charged against your insurance. We're getting into the summer season now, and you all know that it was like 90 degrees yesterday. When you're going out in the sun, I'm just reminding you, I have, and I want to thank you for, I guess I got a lot of phone calls for my birthday when I was interviewing Corrigan, so thank you so much for the congratulations, if we want to call it that. But all my family's coming this weekend, my grandkids, my kids, my great-grandkids, and we're going to, hopefully it doesn't rain us out on Saturday, but we're going to be outside, and hopefully the weekend's bright and shiny, but people are coming in, getting sunburn and getting poison oak. So please use sunscreen before you get out on the lake or before you go out and lay in the sun by the pool. Put it on a half hour before you go out, because most people, especially on a weekend, don't get going till around 10 or 11 o'clock. And by noon they're out there, and then and the most intense sun comes from about 10 o'clock till 2 o'clock in the afternoon or 3, and you get really burned. And I grew up that way. I'm showing signs of that now as I age, that I could have avoided the sun. When I was back in the Midwest, it was very warm, and I was talking about being a road guard on a construction site. And I'm dark complected anyway, and by the end of the summer, I would be almost dark, completely dark from the sun. That all destroys skin tissue and gives you at a high risk for melanoma. Now we're getting some medications that can maybe help melanoma when and if you contract it, but you need to be able to prevent it if you can. And being young and your children being young, I mean, I've got great grandkids that are less than a year old, and I've got grandkids that are in their mid-20s. So. And my kids are nearing mid-40s and some close to 50. So you can see that I'm not a spring chicken. But you still need to, when you're young, you forget about those kind of precautions that you need to make when going outside. When it comes to poison oak, it's every place right now because of the rains we had. And it is one of those things that you can put on a protective layer of a product called Technu, and but if you cover up with long sleeve shirts and hats and gloves and those kind of things, and long pants, not shorts, you will protect yourself considerably, because once it gets into your bloodstream, it's very difficult to control, and you end up probably going on steroids, which is prednisone or cortisone, internally, which has a number of side effects. And in order to get rid of it, it's at least one series of those, and sometimes two, depending on how severe it got in your bloodstream. You also, a friend of mine just got bit by a spider, and it's not a brown recluse, because everybody thinks we have brown recluse spiders in Lake County. We don't. But that doesn't keep you from getting an infection. And if you get bit by a spider and you don't know it, and it starts to fester up, that skin will actually break and become necrotic, or dead skin on the outside, and it will become infected, and it will be painful. That's not something you need to try to treat with triple antibiotic cream. You need to go in and see a doctor. And if it's over the weekend, and then go into the emergency room. But you need to address that issue right away. And if you're a diabetic, you know how long it takes, or if you have any kind of a compromised vascular system, meaning your nerve endings and your blood vessels are compromised in any way, whether it's high cholesterol, whether it's diabetes, whether it's a neuropathy, you're going to have a hard time getting that antibiotic to the site of the infection. So just remember that when you're traveling or when you're infected, you need to get to an antibiotic as soon as possible, and probably you will end up taking more than 10 days worth of that antibiotic if you're compromised in any way. I'm just covering a lot of little things here, but I was traveling the last 2 weeks and went to different parts of the country, and I was in 4 different airports, and in airports, the security lines are unbelievable, and we are not. I started in Sacramento on a Tuesday night. I got into Madison, Wisconsin on Wednesday morning, and I was in Sacramento and Minneapolis and Madison, Wisconsin, and the lines were unbelievable for security. And I have a TSA pre-check number that I pay $85 for to be able to go in the pre-check line. The pre-check line was so big, the other line wasn't as long. And people were getting stopped all the time because of the high security risk. So take your medication with you in your carry-on. Don't put it in your luggage that's being checked, because there's a good chance that luggage will go to another destination, especially if you have to have an intercrossing flight and go to a hub in order to get to another airline, which that's on the way back. Then I went to Madison, Salt Lake City, and Sacramento. So in every one of those situations, even in Salt Lake City at 10 o'clock at night, the security lineup was unbelievable. We're not even in the traveling season yet. So it's going to get worse and worse. Over 100 workers from TSA quit last week or were fired. They're trying to bring in security people from all over the country. What that does is puts a green light upon anybody who's trying to bring something in, because they know that the lines are big and people are irritated, and it's going to be a long, hot summer. So especially with your medication, and you get jostled around, and especially if you don't have a lot of patience. And at this time of year, a lot of people with families are traveling, and they want to get to their destination, and they've already missed 1 or 2 flights, and you're shuffled around to a different seat. The chances of you being diligent about your luggage and your medication is highly risky. So I just had a lady that was in Salt Lake City last Friday night, and she hadn't ever met this gentleman at all, and she had to go to the restroom, and she asked him to watch her luggage. He wouldn't do it. He said, "No, I'm not going to. I don't want it." So she had to take her luggage with her. But the security and the risk out there is very great. So I just want to make sure that you use every kind of precaution that you can to take care of yourself first. The Zika virus is the big thing now, and there's cases of Zika virus all over. We need to educate people the best we can about it. The virus has been detected in most of South and Central America, as well as the Caribbean. And it's transmitted mainly by a certain type of mosquito. But it has the ability to spread broadly and rapidly because of the mosquito. And they are in Florida, they're in California. About 80% of the people who contact the virus don't share any symptoms. It's kind of like Lyme disease. Of course, Lyme disease has that bulletproof or that bullet target area that you can see that starts it out that you've been bitten by a tick. But usually visible symptoms are a rash, fever, joint or body pain, red eyes, all of which can occur with dengue fever or other kinds of diseases that are spread by mosquitoes. So from the outset, the concern with Zika has been it causes microcephaly, which is an abnormally small head in babies born to women who contact the virus during pregnancy. The epidemic started in Brazil in early 2015, and now we're going to the Olympics. If you're going to the Olympics, you need to be extremely careful. But as of a month ago, there had been 2,500 cases of microcephaly, according to the World Health Organization. And, it's been around for a while. It was first diagnosed in Uganda in 1947, and then they occurred in Africa and Polynesia. And I used to go to Polynesia all the time on vacation, to Moorea, outside of Tahiti. And they still have cases there, and they still have them in the Caribbean, and it's traveling. So you need to be educated about preventing the spread. The Center for Disease Control has advised women of reproductive age that engage in pregnancy planning to counseling with their health care providers should avoid traveling to areas where it's actively spreading. And men who have shown symptoms or travel to those areas should use condoms, of course, during sexual activity. So anyone traveling in regions where it's present should be advised to use insect repellents containing DEET or anything that's available outside of the Picardin in conditioned areas, and it should be applied to skin and clothing and should be put on after the sunscreen is applied. So no treatment targets Zika specifically. They're working on a vaccine. We don't know when that would be. Aspirin and non-steroidal anti-inflammatory should be avoided in suspected cases of dengue fever because of the risk of hemorrhage. So it's one more thing that we have to look out for, and it's like we thought about other disease states. We didn't think it would be like Ebola. We didn't think that it would be a cause for concern for us, but it has been. In the last few minutes, and I know you get tired of hearing about this, but the substance abuse and addiction of opiates has just been phenomenal, and it's become a national health emergency because every day the headlines detail the casualties of the nation's surge in heroin and prescription painkiller abuse, and especially the funerals. And now that heroin comes out of Mexico, it's quite cheap. It's also probably the most addictive narcotic that you can be on, and probably one of the most painful withdrawals that you've ever dealt with. So how this public health problem is adding to the nation's healthcare costs, and you're shouldering the burden. The amount of people that get into the emergency room because of opiate overdoses. One of the problems with heroin is the scope of safety is like 1 to 5. I mean, if you get within 5 times the dose of a regular dose, you're dead. And what happens is these people possibly had been on heroin before. Now that it's cheap, they go back and start out at a dose they were on before, and they die. You have seen information in the paper about Sacramento and San Francisco with opiates now being laced with heroin and fentanyl, and people are dying. It's become so desperate on the street to get opiates and the cost of opiates has gotten so great. People are going out on the street to try to get the medication, and they have no idea what they are getting. So it's a lot more expensive to treat. Hospitals charged about $15 billion in 2012 for opiate-related inpatient care. That was more than double what it was 10 years before that. Even accounting for inflation, more than $700 million of that went to treating patients with infections. I just went on the internet this morning and I saw people, there was an article about opiates, and they showed people that were healthy, biceps, and had been taking steroids and things and injecting heroin into their system. And the amount of infections they had on their arm because of the needles. You know, California is one of the more progressive states when it comes to not giving out, but allowing you to purchase needles without an ID, without an age-specific. Just walk into the pharmacy without a prescription, and we, by law, can sell you these without a prescription. At the same time, we try to sell you a sharps container where you can put the medication or the empty syringes in the sharps container and keep them from being laid out on the street. So we want to remind everybody that this is an epidemic in proportions. You're going to see more and more restrictions, even on pain management clinics, which have been in the past people to maybe at will, not in Lake County that I've seen, to give people opiates. Dr. Johnson, who has the pain clinic in Lake County, is very, very precise about prescribing that medication, and many of the times will prescribe a Narcan prescription, naloxone with it, to reverse the opiate if somebody ODs on a dose of what they're taking. The problem is when we prescribe an opiate, we don't know, and I'm saying we, I mean clinicians, we don't know what you're taking with that medication. Frequently there's marijuana. As much as I respect marijuana being used for medical use, it's going to open up all over California for medicinal use, quote, medicinal, quote, unquote, medicinal, and it eventually will be recreational. And you will see a potent amount of marijuana being sold. Right now we're finding people making the concentrated oil to make it more potent, and it's already way more potent than it was back in the 60s and 70s. And you're seeing it all over. And people, although you don't hear about it, and I respect your opinion on medicinal marijuana, but to me it's a gateway drug. I've seen it in too many situations where people have gone from marijuana to hardcore narcotics, and then it really becomes an issue of even surviving, and it becomes more difficult for us to control it. So when a physician prescribes it, they don't know if you're mixing it with alcohol, you're mixing it with fentanyl, you're mixing it with whatever altered substance. We now find out that people are taking Imodium, which is for diarrhea, excuse me, in massive doses to keep them from withdrawing from narcotics, and it's affecting their heart. And the people that have been admitted because of that are now becoming have not made it. Reversing it is not available. Well, I'd like to remind you we're North Lake Medical Pharmacy with 2 locations for you at 5136 Hill Road across from Sutter Lakeside Hospital. Call us there at 263-6192, and outside the Bruno Shop Smart at 347 Lakeport Boulevard. Call us there at 263-1328, and thank you for all the happy birthdays.
And thank you for joining us. Happy birthday again to Bill Kearney. 74 years young today. We wish him another 74.
I hope so.
We'll see everybody back here again next Wednesday for Health Talk on AM 1270 and 96.5 FM KXBX Lakeport.